We want to see what Walgreens is afraid of, what its steps are, and what this means for pharmacists and pharmacy as we continue.
In June 2024, pharmacy chain Walgreens made a shocking announcement.
They plan to close a significant number of stores. At this point, only 75% of stores bring in what is effectively their revenues and profits.
My first question is, what do the other 25% of the stores do? Do they just have lower volumes, and that means they aren't as profitable? Or do these exist for a different reason? For example, you're trying to be in food deserts and in drug deserts, or is there a different reason? You need to look at managing your product flow. You need to look at managing your pharmacy locations. This obviously has problems as we continue, but let's find out a little bit more.
The iconic chain is rapidly reducing its footprint, with approximately 2,150 locations on the chopping block by 2027.
So that's my first question. Why are we waiting till 2027? What has changed? What's going to change between now and then?
This is just the latest effort by the struggling company to right a ship that has seen a rotating door of CEOs, stagnating profits, and its share price fall more than 55% between January and July 2024.
55% drop in 4 months is crazy. What happened there? It's not like people don't suddenly need their drugs. So which means that your profits are going out from the front end. If your profits are going out from the front end, you've got to be considering a few different options. Number one, what is your front end not doing? Number two, are there other services you could deliver, whether we're talking about clinical research, which they shut off, or maybe a minute clinic model, a alternative lab model, which I think was being evaluated. So it's time to look at some new options.
In the Q3 report, CEO Tim Wentworth cited 2 reasons: pressure on the consumer and challenging trends in the pharmacy space.
I wish they'd actually give more details.
They don't have infinite time to stabilize this before it's too late.
But Walgreens' problems are just the latest sign of trouble for the entire industry.
That is completely true. Rite Aid has problems, as we can tell on the screen. But alternatively, we also are looking at problems with just the industry in general, and that goes to reimbursement.
CVS has been closing stores all along. Rite Aid is filing for bankruptcy.
So what is happening to American pharmacy chains? How did Walgreens go from record highs to a bottoming stock price in just under a decade? And
are you, as a small pharmacy, facing the same problem? What has been your take so far?
what does all of this mean for you? In order to better understand the headwinds facing chain pharmacies, we have to separate the store into 2 parts. First, there's front of store, or retail. You know, your over-the-counter cough medicine, paper towels, makeup, candy bars, that kind of stuff. Then there's back of store, or pharmacy. We'll get to that later. First, let's start where everyone starts, walking in the front door.
Walgreens of today looks very much the same of the Walgreens of yesterday.
And I think that is exactly the problem. The Walgreens of today looks exactly the same as the Walgreens of yesterday. What have you changed? Why is today different from before? And you need to have an answer to that question. Where is all the digital health? Where are these clinical research tools we were talking about? There is so much more. Amazon's going to come in and eat your lunch. You need to have a plan. What is that looking like?
It hasn't really evolved and adapted.
When it comes to retail, Walgreens is in the midst of a downward slide, seeing a 4% year-over-year decline in Q3, a continuation of a rough few years for its retail segment.
The front of store offer, where the general merchandise is, the beauty products, isn't that good. It often doesn't look very good. The brands that they have aren't very interesting.
Where are the partnerships? You see Sephora and all of these companies do these amazing partnerships. Where are those partnerships, say, in the beauty aisle? What about other partnerships with other influencers? I'm not talking about influencers behind the counter. Pharma companies will have limitations around that. Also, you may not have the same limitations as a pharmacy as a pharma company does, because you are a healthcare practitioner, you're a healthcare company. The FDA doesn't have the same jurisdiction. In fact, that is exactly what telemedicine companies are all depending on. So maybe Walgreens needs to take a different approach. You have doctors' offices who are focusing, for example, on weight loss. Where is the Walgreens weight loss program?
Prices are often much higher than other destinations. And a lot of people will think, well, yes, I'm here, but why bother paying over the odds?
What we discovered was Walgreens is still operating effectively as the 7-Eleven of pharmacy, which is we're going to give you marked up prices because we're easy, we're convenient. What we've discovered is that the consumer is willing to pay for convenience, but now the definition of convenience has actually changed.
Every couple of years I hear, here's our new plan for the front end. And it's always some new gimmick and then that doesn't work, and then they don't talk about it anymore.
As inflation squeezes customers, chain pharmacies are struggling to compete with cheaper alternatives, like dollar stores and big box retailers.
Which is problematic because they're now aiming for a race to the bottom. And that's great, but maybe start thinking about what your actual audience is looking for. Are you going to put a drugstore product in a white collar type of location? And I think the idea that we can just stamp a Walgreens from location to location needs to change. And I think that's what we need to do as a pharmacy. We need to evolve. We need to understand our consumer. We need to understand our patients.
Offer larger selections and have their own in-house pharmacies.
Particularly our consumer is definitely pressed both from, the ongoing inflation that we've seen, albeit it's somewhat moderating, as well as the amount of money that they just have as we move forward.
It's great that you recognize that these are the issues. However, you've only identified, I think, just one of the issues, which is cost. I would imagine that the big problem you're facing is convenience. You don't want to talk about convenience because if you do talk about convenience, you have to come up with a solution for it. And it's easier not to think of that solution.
Now, Walgreens realizes this is an issue and recently announced plans to lower cost on 1,300 front-of-store items. But it might be too little too late because it's not just the economy that's changed, but the way we shop.
Anybody with a pulse would know what's happening with front end, which is, they're in a pincer movement with Amazon and Walmart getting better and better. They have better price points. The delivery options are getting, quicker and quicker.
Saying exactly the same thing I was saying. How are you fixing these issues? If you're not fixing these issues, if you're not competing with Amazon, you are forcing me to go to a location that I don't want to go to, that I'm not getting any added value out of. And this is true not just for Walgreens. This is true for you as a small pharmacy as well. How are you going to change your model in a way that connects with the consumer, that connects with the patient?
Another frequent pain point for retailers, shrinkage or loss of merchandise.
This has been a problem for most retailers, and I think this problem continues. You need to have a solution to this. Putting everything behind closed doors is problematic at best because you're saying we're going to make it convenient, then I have to go find someone. The store is understaffed. I can't find anyone. I have to now wait, and you've made this a inconvenient process.
Often due to damage or theft. In an interview with the Wall Street Journal, CEO Tim Wentworth cited high theft locations as a factor in determining which stores would be closing.
I don't know what John's going to say, but I think what needs to happen is a discussion with your communities to understand what needs to be done, not just at the retail level, but actually the community level.
Store experience has deteriorated with employee cutbacks and with shoplifting in some locations, as you know, locking the Gillette razors behind the case.
The problem is anti-theft measures aren't popular, as locking necessities behind glass cases doesn't just deter thieves, but it drives away paying customers.
Locking things away behind cabinets is the biggest advertisement for Amazon that you could possibly make, because it just says to the customer, this is a really hard place to shop.
And that's just the headwinds up front.
To avoid legal problems with your pharmacy, call me at 302-252-6959.
8 million vaccines this year at the back of the store already. That's a healthcare business, right? That's not just putting pills in bottles.
When it comes to back-of-house operations, pharmacy and health services are Walgreens' largest source of income. In Q3 2024, pharmacy sales made up 76% of Walgreens.
Now, this is problematic because they're talking about sales, and this is a fundamental misunderstanding of how pharmacies work. Revenue is not the same as profit. The fact that they have 76% of sales coming from the pharmacy does not mean that 76% of the profits come from the pharmacy, and they're being squeezed. In fact, I believe that's what they're going to get into.
Walgreens' U.S. retail pharmacy revenue, and 60% of the company's revenue as a whole. But that's been a declining business for Walgreens, largely thanks to telehealth services and lower reimbursement rates for pharmacy benefit managers, or PBMs. PBM is a company that acts as an intermediary between your insurance and the pharmacy.
Now, it's a really good idea to talk about PBMs because it's a continuing problem. The fact is that the FTC, the Federal Trade Commission, is looking into PBMs as we speak. And it's questionable about what their take is going to be, but it's not looking good for the PBM industry.
With the idea of being a claims processor. So when you bring a prescription to the pharmacy can bill the PBM.
The role of PBMs has since expanded beyond just facilitating reimbursements. They also negotiate drug prices with manufacturers, determine which drugs are covered, set copays, set prior authorization criteria, and decide which pharmacies a patient can go to.
The fact that they decide all of these elements is problematic because if a PBM decides all of those elements, including which pharmacy you can go to, including negotiating the drug prices, and all of this is opaque, that's problematic because now what you're going to have is a situation where you don't know where the costs are coming from. You don't know how to preserve costs. There are rebates, there are minimum threshold volumes, etc. And sometimes, and I know this with smaller pharmacies, you start struggling with PSAOs. And if one PBM throws you out, the others want to throw you out as well. And that's problematic from the methodology of how do you operate.
Where the traditional PBM pricing model fell apart and where there's so much concern is that the entities are being paid to manage drug costs, but typically benefit when drug prices increase, and it creates a misaligned incentive.
The issue for pharmacies is PBMs have been shrinking the reimbursement rates and pushing patients towards generic brands over name brand, a move that helps the PBMs but makes it harder for pharmacies to make money.
They are pushing people towards generics, but generics are also where retail pharmacies can make a lot of money as well. So why not talk to your regular pharmacist? Why not reach out to the pharmacist who is sitting in that store right now and go, what is the best price you can give to me? Alternatively, if you don't want to even go to the pharmacy, you can actually go to like Cost Plus Drugs, and they might be able to give you a better price. If that's not an option, GoodRx is an option. But my point being, PBMs do negotiate good prices, and they can actually get a lot of volume, for example, and that actually brings the cost of drugs down. However, it's not as simple as that. These restrictions are suffocating pharmacies. And it's not just drug companies aren't making the money. Pharmacies aren't making the money. Patients aren't saving the money. Employers aren't saving the money. That money is going to the PBMs, and that's problematic.
The FDA now estimates 91% of prescriptions written in the US are for generic brands.
Historically, pharmacies made more money on generic, less money on brands. Is that with the growth, particularly of the GLP-1s?
Now, this is interesting. They're getting into GLP-1s. And what you'll notice is they talk about it in the context of Walgreens, which I think is actually problematic. And the reason is GLP-1s have been, Ozempic and Mounjaro are examples of GLP-1s. Zepbound is another version of that. The idea being that these products exist so that patients can treat their diabetes, maybe help with weight loss. There's actually some evidence that suggests that it actually helps with Alzheimer's as well. These products have been so successful, they're on shortage, which means that your average Walgreens is not actually compounding them.
For diabetes, the brand volume has increased. And where pharmacies weren't making as much money on brands, as you increase that volume, it creates more and more pressure, reimbursement pressure on the pharmacies.
These GLP-1s are still on shortage. However, on Friday, there was some information suggesting that Lilly had come up with a way to address its shortage issues. Compounding pharmacies will need to be aware. They will need to come up with a plan to address this exact question.
Currently, the three largest PBMs in the US are CVS Caremark, Cigna's Express Scripts, and United Health's Optum Rx. These three companies alone manage almost 80% of all US prescriptions. And yes, you heard that right. CVS owns its own PBM.
Yeah, that's not a conflict of interest at all, is it? And that's exactly what the FTC is looking into.
CVS and CVS Stores, Caremark can set whatever rate it wants with itself, and it's just left pocket, right pocket. Whereas with Walgreens, they're just a straight up price taker.
However, the growth of PBMs has attracted federal attention, which is potentially good news for pharmacies, as the Federal Trade Commission recently announced it plans to sue the nation's 3 largest PBMs, accusing them of illegally driving up drug prices.
So I think anytime we can shine a light on that, put pressure on that to make sure that everyone knows what they're paying for and why they're paying for it. And so at the end of the day, people can afford the medications that they need.
And that's another thing. What's happening to all the people who need these pharmacies? What happens to communities who rely on these pharmacies once they're gone? Pharmacy closure can be detrimental, especially in areas where access is already an issue.
As access becomes an issue, I think people adapt, people change. Is Walgreens ready for that change? You're going to get pharmacists who want to simply answer the phone call and take care of patients. You're going to see new versions of pharmacists that come out who are not just sitting in a retail setting, but they may be doing telehealth. You may see pharmacies and pharmacists getting into reimbursement, compliance, and so much more. If you want to ask me some questions about what are some of the pharmacy options, feel free to reach out to me.
Pharmacy desert, or a place with low geographic access to pharmacies.
The definition of this depends on several things, like the density of the area and the resources of a neighborhood, including the median income of a neighborhood.
Now, I do find it interesting that while there are so many pharmacy schools out there, they went to Jenny, who is in the Health Policy and Management University at California, Berkeley. Why won't you go ask a pharmacy school?
And how many, the vehicle ownership of that neighborhood.
According to the National Institutes of Health, approximately 15.8 million Americans live in a pharmacy desert. An NIH survey of census tracts identified over 4,600 pharmacy deserts in the US.
I've always wondered this, and no one's really been able to define that for me. How do you define a desert? If you said there are 57% or 4,700 pharmacy deserts, what is the location? How do you decide to draw a radius, a circle that identifies the desert? You have 2 deserts that are contiguous to each other, that are next to each other. And in fact, if that happens, should you count them as 1 or 2?
In urban areas.
There are neighborhoods in the south side of Chicago that do not have any pharmacy.
We just talked about the fact that you have retail theft. There are going to be locations, especially in some of the more dangerous urban areas I've lived in, that pharmacies, I remember I wouldn't want to work in those pharmacies because the risk was too high. And I say that as a pharmacist. We need to have a plan. And simply saying we'll shut down those stores may not be enough of a plan.
Like the downtown area, you might have a CVS next to a Walgreens, next to a Rite Aid. Those neighborhoods are wealthier, they're whiter, and there's just more resource than the neighborhoods that don't have pharmacies. So it's not even on average, there's just inequities in the distribution of pharmacy deserts.
So for those people who don't know, there is this whole concept of social determinants of health. And social determinants of health get into exactly these types of issues. This idea that there are food deserts. So you prescribe medication, but people can't even get their pharmacy deserts, where people need access to a drug, but they can't get to a pharmacy. The closest pharmacy is an hour away.
Pharmacy closures predominantly affect low-income urban areas, where the majority of people are on Medicare or Medicaid, plans with lower reimbursement rates compared to private insurers.
If that is really a right sizing, they would be closing in the neighborhoods that have the most pharmacies, not the neighborhoods, the counties, including in rural areas, that have fewer pharmacies on average.
Well, that ignores the fact that there is a safety issue, that there are theft issues, which were just mentioned. So it's great that you say that as a social equity issue, and I think that's wonderful. And it is an issue that needs to be raised, but it needs to be contextualized.
Both CVS and Walgreens acknowledge pharmacy deserts are an issue and claim to be taking that into account when closing stores. Walgreens' CEO told investors, "We are the only thing standing between those places and being pharmacy deserts. And our goal is not simply to be the last one to leave. Our goal is actually to find new ways to work together." CVS CEO Karen Lynch also commented on this topic earlier this year.
And we are also committed to making sure that there's not pharmacy deserts, so we won't close stores where people need access to medication.
If it's a footprint, the argument, that doesn't make sense. Because we know we do have evidence of where they're closing, and it's not in the neighborhoods that have the most pharmacies.
Of course, pharmacies aren't just for picking up prescriptions. Chain pharmacies offer health clinics, COVID testing, vaccines. And it's not just the customers who are impacted. The pharmacists and nearby pharmacy staff who now have to shoulder the burden of displaced customers, all at a time where pharmacists are already staging walkouts and ringing alarm bells over insufficient staffing and corporate mandates.
The fact is that pharmacists are overworked, that we've been squeezing pharmacists the whole time. And pharmacists who do make a decent living are basically deciding I would much rather not make my living doing this. That's how bad it is.
The problem is the average American has almost no say on if a pharmacy stays open or closed in their area, meaning the solution largely falls on legislation to fix.
Regulating PBMs and potentially increasing reimbursement rates for pharmacies that are serving the most marginalized neighborhoods.
That sounds great as a concept, the idea that you will require that certain pharmacies stay open and that private payers would need to increase reimbursement rates. However, why don't we actually start from the government increasing its reimbursement rates, which are known to be problematic?
FTC lawsuit we mentioned earlier could actually lessen the impact of closures. And there's already been movement on the state level.
States obviously have a role. They can also regulate PBMs. They can also ensure that, for example, their Medicaid programs provide higher reimbursement rates for certain pharmacies.
In a statement to CNBC, Walgreens stressed, "We share a deep commitment to offering equitable access to healthcare in the communities we serve. Our priority is to ensure a smooth transition for our customers and team members during that time."
So I'm now confused. There is a transition, but a transition to what? How are you enabling the better care of patients? As a pharmacist, what would you say to your patients to enable them to take these steps?
While painful for communities, from a business standpoint, closing low-performing locations is the solution to a lot of the issues these companies face. And we know it works because someone already did it.
11.3% same-store sales increase at the front of the store for the pharmacy. I mean, that's pretty impressive. What drives gains like that?
Part of it was that they just had greater volumes at the pharmacies. And I remember CVS.
So how do you get greater volumes at the pharmacy? You get greater volume at the pharmacy by essentially shutting down other pharmacies. When those pharmacies shut down, the prescription gets transferred over. You fill your prescription at the new pharmacy, which means for one pharmacist who was doing the work for, say, 500 people, you now have 1,000 people coming, and you're still doing the work for 1,000 people. If you have had that experience, if you are a pharmacist and you thought that you actually had more help, I'd love to get your take. Tell me if I'm wrong. I'd love to hear that.
Has been closing stores all along. They expect to close up to 900 by the end of this year from where they were a couple of years ago.
Other attempts to cut costs include Walgreens pulling out of its primary care endeavor, VillageMD. And Walgreens' Q3 investor call, CEO
getting out of primary MD, which I don't have a problem with necessarily. If you've decided that does not work for you, does not work for your patient population, that's great. However, maybe that should be the conversation. It would be useful to understand what made your decision-making process work. It speaks to food deserts. It speaks to safety issues. That communication may also help decide whether a smaller retail chain or a smaller community place or a smaller pharmacy should get into that space. If there is a true safety issue, we don't want anyone putting their safety at risk. However, if it was simply a issue of we just needed a larger footprint and the location could not support that, well, then maybe a different discussion makes sense.
CEO Tim Wentworth gave investors ideas of where Walgreens is shifting its focus next: health, beauty, and women's health.
I find it fascinating when you pick on beauty and women's health, which are often targeting the same population. I don't see too many men getting into the beauty space. And there's evidence suggesting that men don't take care of their own health, which is why Walgreens is focusing on that. And that makes complete sense. However, who's then going to address the needs for men?
It certainly hasn't taken advantage of very strong areas of growth in the US, like premium beauty. It's allowed Ulta and Sephora and others to really eat up market share in that arena.
And less pharmacies also means better pricing power when it comes to negotiating with PBMs.
One light at the end of the tunnel is on the pharmacy reimbursement. Caremark, I mean, they have said, look, we recognize that what's going on in the U.S. or the drug retail market is not sustainable. So Walgreens could get a new contract from Caremark in 2025.
Now, on the consumer level, there's been an unlikely trend emerging out of these pharmacy closures: a resurgence of independent pharmacies.
It's true that independents close. They close at a much higher rate, but it's actually a question of turnover. So they're more likely to open in rural areas, they're more likely to open in neighborhoods of color and low-income neighborhoods, because that's where chains aren't.
In New York City, less than 1% of the population now lives in a pharmacy desert, a city where as of 2023, only 15% of pharmacies were chains, meaning the mom and pop businesses that were run out by the chain pharmacies could be the solution when those same chains leave.
As they just pointed out, mom and pop stores, I remember 5 years ago, 10 years ago, I had friends who owned pharmacies and they said they simply couldn't sustain it. And I think we're coming back to that pendulum swinging back in a place where small mom and pop stores make sense. However, we need to make sure that they get reimbursed properly. Problems don't go away depending on ownership. Those problems still remain. Another question to ask, do we need to start thinking about whether pharmacists can be the only ones who can own a pharmacy? There are certain states that require pharmacists to be the only ones who can own a pharmacy, and that gets rid of chains. I'm not saying chains are bad. Chains have their role. The question is, if one is purely profit-driven, can you take care of patients in the same way as if you were actually an individually owned or a patient-owned type of a location? And there's more to discuss here, and let me know if you want to get into that conversation.
It definitely creates a business opportunity for an entrepreneur to come in, start their independent pharmacy, and service that area that needs it.
So what's your take? Do you agree with what I was saying? Do you think I'm wrong? I'd love to get your take on this. Having problems with your pharmacy? Reach out to me right now at Darshan at Kulkarni Law.